to the show, where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today in the show, we have Susan Mann and Haywood Brown. They are obstetrician-gynecologists. Dr. Brown is the past president of the American College of Obstetricians and Gynecologists, and together they wrote the Kevin MD article, Reproductive and Abortion Care is Healthcare. Susan and Haywood, welcome to the show.
Thank you.
Thank you, Kevin.
So we'll get into your article in a little bit. We're going to ask each of you to just briefly share your story and journey to where you are today. Susan, why don't you go first?
Sure. I'm a practicing obstetrician gynecologist. I've been at the Beth Israel Deaconess Medical Center in Boston for the past 32 years. I'm originally from the Midwest, from Missouri, actually, and I chose to move to Massachusetts because I believe strongly in women's rights and women's health care. It has been a wonderful journey to support women all these years, and I'm just really concerned about what's on the horizon.
And Susan, what would you say is one of your greatest rewards as a practicing obstetrician gynecologist?
Well, I've delivered probably over 5,000 babies, but that's kind of what we do. The other area around the year 2000, I became very interested in patient safety and communication. And my background is training with the Department of Defense to improve communication among providers. And that's really where my interests have lied in the past 20 years, is to help the communication flow better, both among providers, doctors, nurses, obstetricians, anesthesiologists, and also with our patients. And it's been a wonderful journey.
And Haywood, will you briefly share your story and journey to where you are today?
Absolutely, Kevin. I have been involved in this women's health care and obstetrics and gynecology and preventive care for 40 years now. And my career has been at different states and different institutions. And I started my career basically after my fellowship training, really focusing on health equity, health disparities. I did all of my first academic jobs at large institutions for charity care type institutions, including LSU in New Orleans, Indiana, and so forth and so on. So my focus has always been on all of the things encompassing women's health and women's health care. My rise to become president of ACOG was really focused on that agenda, particularly over the last decade and a half, really focusing on health disparities. But quality care, in fact, Susan and I met because we were doing several quality initiatives together, really addressing maternal mortality and maternal morbidity. And of course, my journey has always been one where I've championed, as Susan has, access to a full range of reproductive services, including abortion services. And fortunately for me, I've never experienced in my professional life a period where I could not advocate for those services or have the ability to provide those services to women. And what this does currently is really put us back, maybe not just 50 years, but maybe 130 years if we think about the implications of what we're going to see with the other attacks that are coming on patient-physician relationships and privacy.
All right, so let's talk about that article both of you wrote. It's titled Reproductive and Abortion Care is Healthcare. Susan, for those who didn't get a chance to read that article, can you just briefly walk my audience through it and share the story of why you and Haywood decided to write it?
Absolutely. Thank you, Kevin. When the leak came out about what was coming potentially from the Supreme Court in terms of limitations on abortion, many of us that provide care thought that things might be scaled back, that maybe it might be reduced to 15 weeks. But I think pretty much universally, it was just such a gut punch to think that all abortions could be taken away from women and returned to states' rights. But what that means is the day it is signed, there are 26 out of 50 states that have laws either already on the books or will take effect again where a woman can't get these services. And period. And when you've practiced for so long, when that door closes in the exam room and it's you and the patient, and you hear their stories and their concerns and what they've been through, whether it was a sexual assault, whether it was a very desired pregnancy and now the baby has congenital anomalies that are not compatible in life, or whether it is a problem with the placenta, all types of things that we see in our practice. 95% of the time, people think I have the best job in the world. Delivering babies is great. But, there's about a 2.5 to 5% of the time that it is one of the worst jobs to have to deliver news to people. And to think that there are men, predominantly men, that have no medical training that are making decisions that no longer allow people to make these decisions for themselves. Couples, women, to make decisions for themselves when their lives are at stake. I can't think of any other time in medicine where the desires of others are imposed with me and my patients in our exam room, talking about options that for the most part are really difficult options for patients to take on board. And now not to be able to give them options, to be able to look them in the eye and say, last month we could have taken care of this, but this month your life is now at risk, was so fundamental to my nature that I had to take up the pen, that I had to really sound the alarm for my physician friends. There's just so much going on in our world right now. We can't let this just be one more thing that we absorb and move on. We have to pay attention to this.
So I'm going to ask both of you the same question, and that's to take us into the exam room. Assuming that there are no changes to the draft opinion, can you give us an example or a case study of how this would affect your life as a physician? Susan, why don't you go first?
I'm very fortunate. I practice in Massachusetts. Massachusetts has tried to strengthen their abortion rights laws. So I feel that I will be able to continue my practice for now. And I say now with a line under it. The line is under it because you've heard from Senate Leader McConnell say, no, actually, if the Republicans come into power, we want to make this law the law of the land, regardless of what state you're in. So now, if you then take it to that degree, how would it affect my practice? I almost can't quite wrap my brain around it. To have somebody that has, and we've seen these cases, have a placenta abnormality where it's overlying the cervix and the patient starts bleeding at 17 weeks and you've had to transfuse them 1 or 2 units, and that there's potentially 20 more weeks to go of their pregnancy before you could perhaps take care of this problem. It just puts her at risk, so much risk. And that you would have to, I guess, wait till 24 weeks to deliver the baby. I can't even work out the algorithm of how you would care for these people. It is just so frightening to me what is potentially on the horizon.
Kevin, I'm gonna take you into the exam room of 3 previous cases I've had to deal with where the woman made a decision to not continue their pregnancy. And these are from the past of my history. But what would happen if those women were coming into the exam room now with the limited options? And let me take the serious one of a woman who finds herself pregnant with a stage 4 breast cancer, having to make a decision about treatment. Let's put her, like my patient was, already at 11 weeks with a very desired pregnancy, but really having to postpone her treatment now for another 30 weeks or 20 weeks before she could literally deliver. Tough decision. She made a decision to terminate the pregnancy because she needed to undergo major radiation and chemotherapy and surgery. And fortunately, I know the story goes is that she later had another child that we were able to take care of her. Taken to the exam room of a 12-year-old who's pregnant, who's born in by her mother. She's now 15 to 16 weeks, just found out she was pregnant. And she is now in a situation where she is pregnant because the boyfriend raped her, period. We have states now who are saying that there should be no exception for rape or incest. So how can you say that you're pro-child if you can't think about that same 12-year-old that I had that many years ago who really would not have been able to exercise the option of a pregnancy termination? So those are just two examples. And I think to ignore the long-term issues of things like the psychological stress, the emotional stress that we now follow, and Susan and I've seen these women, we followed them for years with the trauma that they've endured, not just from the rape, but just from the pregnancy and having it. So these are real scenarios. These are real issues now that we would have to deal with that. And we would have to try to figure out ways to help these women to navigate that process. If they were in a state that had a trigger law that said, no, 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 because we've heard politicians say, well, you know, it was conceived by rape in a 12-year-old, but it's still a baby, you know? And so ignore the mother, the 12-year-old, but take the side of the embryo. What kind of logic is that? And so this is what I think that we're dealing with today, and we have to be concerned about that. We must be concerned about it. Women need to be concerned about it. Men need to be concerned about it. Churches need to be concerned about it. Communities need to be concerned about it. This is where we are.
And Kevin, the truth is, you know, in these states, people that have means will find a way to travel, be it to Massachusetts, New York, California, Colorado, but people without means, and we see so much when you look at the studies of what has happened with abortion over the last few years. If you use long-acting contraceptives, we've seen the rates of abortion and teen pregnancies go down. And we're worried that the future is that these types of contraceptives are at risk as well. But if you have means, so you'll travel to Massachusetts. And if it becomes a law of the United States, you'll go to Canada or South America. Mexico now allows abortion, right?
Mexico.
Right.
Yeah.
But if you don't have the means to take on one more child and try and support one more child when you're already financially strapped, you just have to wonder, what are we doing for these people? What are their lives and the quality of their lives? It's just yet again an example of the unfairness that exists in our healthcare system. And we also know, if you then flip it on its head, maternal mortality is 3 to 4 times in a Black woman or in a Native American woman that of a white woman. And it just, it doesn't stop. This just keeps compounding.
Well, Kevin, let me give you a historical perspective, because if this decision is upheld to undo Roe, it undoes Planned Parenthood versus Casey, which may not mean anything to anyone other than that was the original challenge that produced undue burden. And so undue burden is really about a person having to travel more than 100 miles to get a pregnancy termination. So basically, Roe undoes Casey. Well, perhaps Roe also undo Griswold, which is the right for married women and men to use contraception. And so getting back to Susan's point is that there are certain contraceptive methods that are proven to be most effective for pregnancy prevention that could be challenged, and that is including intrauterine devices, because there are, quote, small minority of individuals who believe they prevent implantation. As long as that mentality is there, rather than the fact they are hormonal and so forth and so on, you're going to have people who will go after those. So who's to say to me now in my room, when I have a woman who wants to have an intrauterine contraceptive device, a long-acting contraceptive method, you can't have that because the law says that this may cause the pregnancy not to implant. The most effective method of contraceptive that we have for pregnancy prevention, there are people out there who want to do that because they have personalized the conception. That's how tragic this is and how demeaning it is to women's reproductive rights.
And it goes on even further, Kevin. If you take it to where a subset of our population wants to go, personhood becomes when the egg is fertilized. So if you take women that undergo IVF, which has been a godsend for so many women and allowed women and men to have families, IVF is at risk because if a woman conceives and has 10 embryos, right now she may freeze them, she may use them for a later pregnancy, she may choose to discard them. But if you say that a fertilized embryo is a person or give it personhood status, then there are three options. You can put all 10 back in the uterus. You can allow another family, donate them to another family, but that's kind of a difficult decision and whether you want your DNA spread across multiple families, or you pay for refrigeration fees for eternity. But if the freezer breaks, then you're at risk for committing murder in their eyes. And so that puts a complete chill on the IVF colleagues that perform these kinds of services. So I just don't think that the average physician understands what's coming down the pike if this decision's really allowed to stand and some of these other add-on decisions come to fruition.
The criminalization, that goes along with some of these laws. I mean, like the Texas law, bounty hunters out there saying, okay, if you do this, there's a bounty on you. Well, we've already seen people who provide abortion services have bounties on them and killed. I mean, that's been going on it has happened several times for prominent physicians in their community. But, this is murdering someone to, quote, keep them from performing a service that women come for. That's legal. That's legal. So, now you have Texas with a bounty law. If you can be turned in, but a number of other states who are actually going to trigger that too, where you begin to say, well, if you do perform this abortion on this person, that we're going to report you and you're going to jail. That takes us back to the Comstock laws of 1893. 1893?
So putting in context about the political and societal climate that we live in, what do both of you anticipate the next few months to realistically bring? What can we expect in the next 3 to 6 months? Susan.
I fear that the opinion that was leaked is going to become law of the land. I don't think that there will be an expansion of the Supreme Court in the near future. I hope that it will galvanize women, and I hope that as physicians, I think it is okay to educate women in your exam room to get out the vote, because it is important for them to preserve their rights, for us to all work together. And if women don't get out the vote and encourage their male partners to get out the vote, it's the only way that I see the situation changing, is to elect officials that represent the majority's view.
I think the issue is how short-sighted the immediacy of this. Keep in mind that we've been trying to work on this for 50 years of overturning Roe. I mean, so it's never going to be those individuals who are going to be completely cured. What I was hoping for is that not a complete reversal of Roe, but really was the fact that the case that was being looked at was a 15-week, limitation with exceptions for rape, incest, and so that, all those type of things that may be more logically sensed. But those individuals who firmly believe that this is all or none, it's all or none, when the population is 70% in favor of women having the right to, it ignores all that. And so this is where we have to go. We have to be prepared to help women. We have to be prepared for helping women to exercise their options wherever they can get. The biggest group that will be penalized, of course, people who have access issues already, who have dollar issues already, who have counseling issues already, individuals that they can see. And so the idea of us being able to band together and look at where we can help a woman exercise their options are really the things that I want to take home. But I also want people to think, as Susan has said, about what the political implications are for the embryo. What are the implications? What happens to the millions of frozen embryos around the country. They become wards of where they're being frozen. What happens to long-acting contraception? But ultimately, what happens to the physician-patient relationship and the right to privacy? Have we really now said that you have no right to privacy when it comes to exercising your reproductive rights? If we're really saying to people, you have no right to privacy, period, when it comes to pregnancy and this issue. And essentially, has that not what's been said? That is what's been said. You have no right to privacy.
And you can take it back to the original Constitution. I mean, women were not included in the original Constitution, but the right to life, liberty, and pursuit of happiness. Well, forcing someone to carry a pregnancy after rape or incest doesn't fall in any of those categories. Life of the mother at a time of a difficult pregnancy doesn't fall into any of those categories. So why is it that we can revise it now based on the opinion of a few?
The last thing I would like to say is when you present that to people, you would think they would be logical. But what I've heard a number of times on this issue, and even in the issue of maternal mortality, when we were fighting to improve the health of women in general, you will have a political person say to me, well, if they die, it's God's will. They don't understand that my whole teaching is God gave you talented, brilliant surgeons and people who would care for us that evolved over the years. So it doesn't have to be God's will that someone dies, you know? We can save lives. That's what we do. And in many instances, what I'm saying is that we are saving the lives of women. We're saving the lives of many children. We're saving the lives of the long-term health. And I believe that when that is so short-sighted, that people are forgetting about the fact that they have daughters, they have sons. And it's really different when it's you. Truzen, trust me, I trained in the South, and I would tell you, when it's your daughter, it's different. You make different decisions, and that happens all the time. And that's the hypocritical aspect of it that is just so hard to deal with.
Susan, I'm going to give you the last word. What are some of your take-home messages that you want to leave with the Kevin MD audience? It's
really time to pay attention to this matter. This can't just be, oh, it's one more thing that's going on in the world. This is a stop, and pay attention and become actively involved issue. Because if we don't, the ramifications are just so significant for our lives as clinicians and for our patients' lives.
Susan and Haywood, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you.
Kevin, thank you very much for allowing us to be on.